Welcome to the SPRT Therapy Podcast, where top doctors, trainers, and athletes share their secrets to moving better, recovering better, and performing better.
I'm going to tell you right now, if it wasn't for Tim Brown, I would have never walked again or surfed.
Come a little bit closer, hear what I have to say.
Please join hosts Dr. Tim Brown and Dr. John Pecora for today's conversation.
All right. Thanks so much for joining us for the SPRT Therapy Podcast. I'm Dr. John Pecora.
Hi, I'm Tim Brown.
And we're joined today by our good friend and brilliant clinician and instructor, Dr. Michael Rintala, who will be discussing the educational module we recorded yesterday with Web Exercises Academy on dynamic neuromuscular stabilization. Mike, how you doing?
I'm great. Thank you for having me on this podcast, you guys.
It's a pleasure. If you are a DC, a PT, or a trainer and you'd like to watch the hour-long module we recorded yesterday and need CEs, please visit webexercisesacademy.com. Mike will also be presenting this info live and in person at the SPRT Therapy Sports Movement Symposium in Newport Beach this June, alongside former Los Angeles Lakers head PT Dr. Drew Marcos from Modus Physical Therapy. Mike, maybe before we get started, if you could just give a quick background on your history, how you kind of got into sports chiropractic and, being a younger athlete, and then the progression maybe into how you became familiar with and pursued dynamic neuromuscular stabilization, DNS, how everybody refers to it.
Sure. I guess the driving force that brought me to where I am today was my own participation in athletics. Early on, I was involved with all different sports: baseball, soccer, basketball. And what I found over time. My sport that I kind of fell in love with and that I kind of obsessed over and pursued was tennis. And so, early on, I played junior tennis and eventually college tennis. And the overuse injuries and chronic injuries that I experienced playing that sport and training the way I did and looking back, overtraining the way that I did, really, I probably spent as much time in the training room as I did on the court, so, but early on and being young, you get away with it, you keep going and you keep going until you get hurt again, and then you rest. And then you keep going again. So, that cycle keeps repeating itself. And especially with overtraining, you just develop these chronic overuse injuries. But you still have the drive and the desire to play and to perform and try to reach your ultimate potential. And it wasn't until I reached, college level where basically the wheels came off. I maxed out on my capacity, developed pars fracture, spondylolisthesis, and prior to that, numerous injuries, groin strains, shoulder impingement, hip impingement, but just kept, pounding my head against the wall until the pars fracture is the one that took me out and took me out hard. And that's the one that didn't go away, that I couldn't recover from and get back to playing how I wanted to play. And not only that, but I couldn't get out of pain. So at that point, we had the trainers and they did the best they could. Had the orthopedist and the evaluation, and eventually MRI showing the pars fracture. And then I started the rehabilitation process with the ATCs and the PTs, and that didn't get me to where I wanted to be or where I needed to be to get back to, performing how I wanted to. And up to that point, don't think I'd ever heard of a chiropractor. And, but, you know, not getting the results that I wanted, I started to, look around and try to figure this out myself. And I saw, oh, chiropractor. Okay, that sounds interesting. And that's something that maybe will help. And, went to a number of chiropractors and, felt good, helped for a little bit, but still it wasn't getting me back to what I needed as far as getting back to playing. It wasn't until I found this one chiropractor, I forget his name, but he was a PT and a DC. And I saw him then blending the manipulation and mobilization with physical therapy. And that's the thing that kind of moved the needle a little bit in the direction that I needed to go, but still couldn't shake the symptoms, and again couldn't perform how I wanted to perform. So about this time, a year or two had gone by. I wasn't getting back to being able to play, and now I'm thinking, okay, what's my next step? Because of course I wanted to just keep playing and try to make the pro circuit, etc. And all my time in the training room, I loved what the trainers did and how they treated, and so that's something that I wanted to pursue. But dealing with my symptoms and basically chronic pain at this point, um, I started to look more at the physical therapist route. Um, but then, okay, I saw the value of the chiropractic route as well. So looking at it a little bit more, I'm like, okay, wait, if I get my chiropractic degree, I can do the things that the trainer and the PT are doing. So I chose that route. Um, and, you know, when I got into chiropractic school, I was like, what did I get myself into? And uh, it wasn't until like a year in where we got some rehabilitation uh, coursework that I got introduced to Prague School of Rehabilitation, and that was Vladimir Yanda, Carl Levitt were the main people that we studied. Once I saw that, um, you know, that clicked. That made sense. Yeah, that made sense. And so, read up on as much as that as I could, combined it with, soft tissue work that I was doing. And that's what really started giving me, and, this is even in chiropractic school, which, you're sitting all the time and still in chronic pain. But integrating some of those ideas out of Prague School of Rehabilitation, that really started to move the needle. And so I kept pursuing that, kept integrating what I had learned with that as best I could. And then graduated from chiropractic school, took a couple years working on the rehab diplomate. And then once I saved up enough money, went over to Prague, and this was around 2003. And there, it was a 8-day long kind of immersive coursework, and it was saw Carl Levitt. Unfortunately, Vladimir Yanda had passed away the year before, so I didn't get to see him. Vele and various other Prague School kind of pioneers, as well as the physiotherapists that were working there at that time, the young physiotherapists. And that's where I got introduced to Professor Pavel Kolaj, who is the developer, kind of founder of dynamic neuromuscular stabilization, or DNS. And at that time, it was just, it's just his ideas. He was talking a lot about developmental kinesiology, integrating that knowledge to assess and treat. Um, he was a pediatric physiotherapist, so he treat pediatrics. He treated general population, had a focus or specialty in cerebral palsy, but he also was head clinician for the Czech Olympic teams, national soccer, hockey, men's and women's tennis. So he has all this experience in all these different populations, and especially with pediatrics and developmental kinesiologists, uh, kinesiology, and postural ontogenesis, which is a study of motor development after birth. So he had all these concepts and principles and ideas, and he was demonstrating the integration of that. And that was all basically an evolution off of Levitt, Yonda, and a pediatric neurologist named Václav Vojta. And so, once I saw that, I'm like, okay, this is makes total sense. It's how I want to practice, and this is on top of, at this point, I think we talked about it on the within the presentation, John, or earlier. This is on top of the experience and knowledge I had of working with Tim, as a student, going out to the different events, the Pro Surf, Pro Beach Volleyball, and seeing that multidisciplinary approach and the amazing docs that he would have come in, and the amazing doc that he is himself. And so I already had that base of, the soft tissue work and the integration of taping and the different assessments. And then I see Prague School Rehabilitation and Professor Collage, and I'm like, oh man, this is like, another huge base of knowledge and skill set that I want to put on top of what I have already learned and am continuing to learn. And so from that point, I kept going over there. They eventually started coming back over here, and I watched their concepts and principles evolve. At that time, it wasn't called DNS. They didn't have any structured coursework, really. And it wasn't until, I think, around 2006 or 7 that they actually had the DNS coursework. So I watched the whole evolution of DNS and Professor Collage, and how his brain worked, and how he was integrating all this stuff. And they integrate soft tissue work, fascial work, visceral work, mobilization, taping. They work as all the different therapists are learning from each other, challenging each other. And the beauty of it is just, Prague School keeps evolving and keeps improving and adding to the base of knowledge and skills that they have. And now I'm just trying to keep up and trying to try to get as good as I can as a clinician, to help the people that I work with. So that's kind of my story, and I'm sticking to it.
That's great stuff, man. Really good
Right.
stuff, Michael. Thanks for sharing that. I've known you for a long time, and I didn't know everything that you went through. So that was great to hear, and it makes even more sense now why we kind of work in lockstep pretty good together over the last 20 maybe plus years. So
Yeah, great info. And maybe before we go any further, if it would be great to circle back on your background a little bit, just so we can kind of finish that. And you spent a number of years on the PGA Tour. Can you kind of talk about, you went from school to spending some time with Tim and others on the AVP and the WSL, or actually it was the ASP, I think, at the time. And then can you just kind of talk a little bit about how you were exposed to the PGA and how that process kind of went down?
Yeah. So I think it was 2004. The PGA Tour was coming to town up at Torrey Pines, and at that time, God, I forget the name of the PT group, but there's some big financial scandal with the PT group that had, Tim, you may remember the name, but anyways,
Yeah, yeah.
so the PGA Tour was cleaning house, getting rid of them, and so they came to town and they were asking all the local sports medicine docs of chiropractors that they'd recommend, because they had full-time PTs out there, they had athletic trainers, but the players wanted chiros as well. And so PGA Tour came to town. One of sports medicine docs that I knew and had worked with gave him my name and said, "Hey, they're looking for people. Would you want to go out and help?" I'm like, "Yeah." And I already had the experience of working with Tim and on the different tours and in the in the tent. So I knew the model in all the other sports, and it's the same on the tour, right? You work as a team, and everybody has their strengths and weaknesses, and you try to, in those cases, you're trying to help the players either rehab from injuries or to be able to keep playing, or dealing with any acute situations. So anyways, I just thought they had me come out for a day, and I was like, okay, yeah, cool. I didn't know it was like kind of a tryout, because they had other docs on other days, and my information was like, hey, they need help. I gave them your name. If you want to do it, give this guy a call. So, anyways, I went out for the day. Um, you know, Worked with the PTs, discussed cases with them. You know, anyway, all the stuff that we would do on the AVP and the surf tour, and you know, talk to people, get their opinions. Anyways, end of the day, um, the head PT comes up. He's like, "Hey, good job," and I'm like, "Thanks. Let me know if you guys are coming around next year. If you need help, I'd love to help out." He's like, "Really, good job." I'm like, "Okay, thank you." And so left, and then like a week or two later, got a call, and he's like, "You want to come out, and do more tournaments and help us out? We really liked how how you worked, your approach." Again, it was a combination. It wasn't. I was mobilizing. I was doing the soft tissue work. I was, some taping, um, and they're like, okay, this guy is a team player, and they wanted me on their team. So that was my kind of entry into the tour. Prior to that, I was doing a bunch of action sports stuff, which was fun, but then transitioned into the tour, because I wanted, like, I just think I was out like 8 to 10 times throughout the year. And yeah, did that, I think, for 10 or 12 years. Have kind of backed off a lot since the pandemic. Now I'm teaching more, and, busy at the clinic, and, want to be around for family. So,
And it's a pretty interesting production, right, with the PGA, as far as the trucks and the trailers that they haul around. Could you just kind of talk a little bit about what that's like, and how the team kind of works together, and the golfers just kind of come in and they approach you? Can you just give a little insight into that process and what it's kind of like on the tour?
yeah, so there's two big trailers that travel to each location. Actually, they have four trailers, because they cover the Champions Tour as well. One trailer is all kind of rehab, so that the PTs are in there, and then there's, I think, 10 or 12 chiros across the nation that cover different regions, and I was one of them. So we would be on the treatment trailer, and then the other trailer was full of workout equipment, And there was an ATC there helping, players with workouts. And on that trailer, the private guys could utilize it. The private guys, meaning the guys that traveled with groups of players or specific players. We were the tour, hired us to take care of everybody. So it could be the guy who just got his card, coming in the door, or it could be Tiger Woods. And so, and then a lot of the private guys, if they weren't out there, then the guys would come see us. So saw all levels, all probably most of the players out there, and each stop they would have a local ortho that would also check in, if players needed an ortho or eval. It's usually for meds or injections and other things. So that's how that whole system worked. And great experience. Enjoy working on every type of athlete, and golfers are definitely unique. And so, yeah, good experience, and fun as well, even though I'm suck at golfing.
Everybody does.
Yeah.
Most everybody.
Yeah. Luckily, it's not a prerequisite to work on
Yeah,
the course, right?
exactly.
Same with surfing. Yeah.
I'm intrigued by all the subsystems and how they work together, and how we're at the juxtaposition in education where we learn everything as single units, not how they work together. And so, being an athlete and being injured often and looking for solutions such as you have in your history, and John, you as well, um, it's no wonder that we fall into this menagerie of approaches, because there's not one approach that fits everything, and not one profession fits all the approaches that we need to take with these athletes. So learning from each other, learning to work with each other, and challenging, you said that as well, challenging each other, I think are great things that will remain on the bleeding edge for many, many, many generations to come, because there's so much to figure out, right? The more I learn, the less I find I know. So, so thank you for that, and thanks for sharing that. And just what are your thoughts on the visceral work? I'm working on that a bit now, working with the fascia that separates the organs, that protects the organs, and allows the organs to move right within their chambers. So,
Mhm.
what are your thoughts on that? What's your latest thought, I should say, on that?
Right. So I think it can play a huge component to some of the issues that we see, and especially chronic issues, especially if, as a clinician, we're doing the tissue work, we're mobilizing, we're giving specific exercises to help with the rehabilitation. But if we're not, still not moving and getting the momentum that we need, that deeper layer is something that we need to address, because the motility of the viscera can affect the tone, and not only of the musculature, but the fascia. It can be a big component of addressing the total person, the total being, to help us move them forward to achieve the goals that they want to achieve. And with the viscera, Prague School, there's this clinician, PhD. He specializes in visceral mobilization and integrated into the DNS concepts and principles. And there's separate coursework that you can take to address that. I've also done some of the Brawl,
Mm.
visceral mob as well. So, but all of that it's almost its own specialty, especially
Yeah, it truly
this
is.
away.
It truly
Yeah,
is. Like, again, filtering us back towards, hey, we're way better together than we are apart.
right.
And the thing that we really stressed in our initially multidisciplinary, and then we understood there's a subset to that, which is interdisciplinary, meaning that you actually talk with each other and you actually communicate for the good of the patient. And
Yeah.
and that there's a big separation there between multidisciplinary and interdisciplinary in my experience. And when you get people talking together, like you mentioned, and then you get to know each other so that you can challenge each other, I think it's wonderful because our goals are the same, but our experiences in getting there are completely different. And that's why I
Mhm.
think together we can integrate and choose what's best. The patient chooses what's best for them based upon the option that you give them, the menu that you
Right.
give them, based upon your consultation together. So I think it's really powerful, and it's the only way that we're ever going to progress because figuring out how the body works and how to make it healthy 24/7 for your whole life. I don't know that that program exists yet, though we're moving in that direction as best we can. Um, it's so we're so dynamic, right? There's so many different variables going on in everybody's body, yours, mine, and John's being our own separate entities there.
Mhm.
So the other piece of that is I wanted to add on to that, and that's what DNS does so well, is that it's all about, you can do great. We do some neat taping and some unbelievable tissue work that gets fantastic results, but we become an aspirin and a band-aid if the patient doesn't change the shapes that got him there in the first place. You've got to
Mhm.
change shapes often. And I use the changing shapes piece. That's Kelly Starrett's stuff. But changing shapes is brilliant. You can't just rely on, just like going out for a run and thinking that's your all the fitness that you need. It doesn't work that way. There are too many other substructure systems that we need to work with. So, that's a big piece of it is changing shapes. How often do you recommend people change shapes during the day, like meaningful, like getting into different postures or positions or movements? How often do you recommend that happens during the day, and for how long?
Right. So, um, coming at the view or the DNS approach, one of the big things with the assessments is we're assessing the efficiency of the central nervous system to express these inborn hardwired motor patterns that facilitate uh, coordinated stabilizing function through the trunk and the pelvis, and then also coordinate not only stabilization but respiration.
Yeah,
And this is all happening subcortically to during dynamic movement. And you can train your eye, you can train your palpation to recognize the inefficiencies or efficiency. And so the thing, if everything's on point, we get synergy, coordination, timing of that deep stabilizing system. We get synergy of agonist, antagonist throughout the chains of movement, and everybody's happy.
yeah,
But the things that usually throw it off are postural habituation, repetitive motions, repetitive use, past injury, and then you can also go all the way back to the quality of development during the first year of life, where our postural foundations are expressed and established. But
can
usually
you
we're
throw
looking,
can you throw quality of breath in there as well?
yeah. Well,
Yeah,
that's huge because um, with the if the central nervous system is on point, then with respiration, when we take a breath in, the diaphragm's going to contract, drop, spread, descend. And this then will, with that descending of the diaphragm, the lungs expand, air comes in, and then recoil, and air comes out. So there's a respiratory function of the diaphragm. There's stabilizing function of the diaphragm. Diaphragm initiates the stabilizing function. So with any movement, any anticipatory movement, you'll see um, like 400 milliseconds before the movement, the diaphragm will descend. It'll create intra-abdominal pressure that pressure loads pelvic floor, the entire abdominal wall. So there's eccentric, then isometric, but then we're fluctuating between eccentric, isometric, concentric to manage that intra-abdominal pressure, which then manages the stable stability through the trunk and the pelvis. And so if you, with assessment, if you're looking at assessing respiration is huge. If you find that the diaphragm's not dropping and descending, we're not getting this ideal expansion, through the lower ribs and the abdominal wall, then we'll see more of a compensatory pattern where if we can't get that dropping and descending of the diaphragm to get the expansion of the lungs, the brain's going to get it somewhere else, and it goes to the accessory breathing musculature, which if there's a time and place for that, but it should be coordinated with the diaphragm descending and the accessory breathing musculature to create this nice expansion of the whole thoracic cage. With inefficiency or dysfunction or inhibition of the diaphragm dropping and descending with respiration, you'll also tend to see a lack of the diaphragm performing the stabilizing function efficiently. So Carl Levitt had this quote where he said, if breathing is not normalized, then no other function can be. And
Powerful right there.
and to that point, if the diaphragm's able to descend and expand, not only are we getting the air into the lungs, not only are we going to be able to facilitate intra-abdominal pressure that will be appropriate for the stability that we need, but we're also mobilizing the viscera. So with ideal respiratory function, ideal diaphragm function, you see this nice motility of the viscera. And if the viscera is moving nicely, usually it's going to be healthy. Yeah. So, but to the other point, things that also could throw off that ideal synergy coordination timing of what I just talked about, if we have pathology in one of the organs, right? Kidney, pancreas, intestines, gallbladder, that can throw off the whole coordinated activity as well. So,
do you believe surgery to those organs also basically do the same thing because of the scarring that those the layers of tissue that have to enter that organ surgically?
Yeah, scar tissue adhesions that can compromise that motility. So, I mean, there's going to be a time and place, right? Maybe we have to get something taken out for some reason, but then we're going to need to address the deep fascial restrictions, the scar tissue as well. Otherwise, if you don't address the specific soft tissues, fascia, connective tissue, if you don't address joint function, mobility, then you can give great, loading and cueing and great exercises, but you're going to run into the soft tissue wall or fascial wall or joint restriction wall that's going to throw you back into the high threshold compensatory pattern that is then overloading the passive structures throughout the chains of movement. And that could be hip, shoulder, facet, whatever.
Choose your spot.
Be. Yeah.
So maybe to kind of explain a little bit more, or just kind of simplify, the concept of DNS. I mean, I have to imagine, as a tennis player with, lumbar stress fractures, finding a process and a concept that really integrates core stability and control, which obviously is, large part of that, or a big player. Can you kind of talk about, yesterday we spoke briefly on, Yonda and Levitt and Vojta, but can you just give kind of a little bit of history of DNS, and then maybe let's pull up your deck and just go through a few of the slides just so that you can kind of give, you're just explaining to Tim after his question regarding, breath and respiration. there's that great example of the diaphragm moving, the rib, the rib cage. And can you maybe just
Hmm.
give a little history on DNS, and then we'll pull up and just kind of show a few of those slides, and then kind of go into questions.
Yeah. So, well, Prague School of Rehabilitation, I think it was established like the 40s and 50s, and that was Yonda Levitt, Václav Vojta, pediatric neurologists. I think Vele. There's numerous people that kind of founded it, but the ones that people usually know are Levitt and Yonda. And collage, Levitt, Yonda, and all these amazing, neurologists and therapists were his teachers, mentors, and colleagues. He worked with them all, and the probably the primary one with the biggest influence on the concepts and principles of dynamic neuromuscular stabilization was Václav Vojta. Vojta, again, pediatric neurologist. This is the time where the Czech Republic, I think it was called, I forget the name at that time, but Czech Republic was Eastern Bloc, so behind the wall. Communists had were in control. Vojta was very outspoken against the communists, and so they took him and they sent him out into the forest, into this facility where they would send all the cerebral palsy kids and hardcore neurologic cases. And so just being in that environment, he recognized, the his big contribution, I think, was recognizing, ideal development and the influence of ideal development on ideal motor function, stabilization, respiration, coordination of both for efficient movement. And during his time there, he figured out ways to assess these infants and recognize early on by looking at their postural reactions, like putting them in different positions, seeing how they reacted, assessing primitive reflexes, and then also just spontaneous movements. Knowing developmental kinesiology at specific developmental milestones, we should see certain things. So he could tell where they were biological age versus chronological age, meaning if an infant was 6 months, but he's showing newborn, biological age, then there's something going on. So they're behind the wall. Technology is probably not the strong point there, so they have to rely on their hands and their eyes, observing and developing that muscle and that skill. And so um, he was able to develop these ways of recognizing early on the difference between chronological and biological age, and the earlier that they could intervene with these, especially with cerebral palsy of the lesion in the central nervous system, the earlier they could intervene, the more advantage they could take with the neuroplasticity of the infant and work around the lesion to be able to facilitate the potential that was there.
Wow.
So it could be the difference between, infant being wheelchair bound or maybe being able to ambulate.
Wow.
And,
Massive.
there could be improvements with speech or fine motor skills, not curing it, but improving function. So that was, and Professor Collage, cerebral palsy was his, uh, one of his main focuses, and he worked a lot with Vojta. But then you have Collage again, taking that experience, that knowledge, but then also he was a gymnast, like Olympic level gymnast, so he had his own sport experience, his own injuries, questions of why, why am I always getting injured, what's the deal? So that combination of things, again, he came up with the concepts and principles of dynamic neuromuscular stabilization. And
That's wild, Mike. That Yonda also, his background was having polio as a kid,
yeah,
right? So
yeah,
everybody, even on this podcast right now, everybody has their motivations. Mine are rooted in sports injuries, and sounds like you
yeah,
guys too.
yeah.
But we have those motivations based on our experiences.
And collage, I mean, hip, but he's, has ankylosing spondylitis. So he has a motivation, right?
Yeah,
To
boy, I'll
figure out
say,
how do we maintain as best we can.
wow.
So, but yeah, that's a little bit about the history of Prague School, just the evolution and with Yonda, what Yonda was seen with upper and lower cross syndromes, that was a result of inefficiencies of that deep stabilization system, the inefficiencies of the coordination of respiratory and postural function of the diaphragm. You see, adaptive shortening and tightening certain musculature, disuse, lengthening in other musculature. So again, Pavel, then you have Levitt, right? Levitt was known for his mobilizations and, the things he came up manually to address what they were seeing. And so then you have this next generation of collage, um, evolving those ideas and those concepts and principles into the DNS concepts and principles. But now you have like 25 or 30 Prague School therapists, instructors, who's going to be this next generation that's also continuing to evolve all this work. So again, that's the beauty of it. It keeps evolving, it keeps improving, and it's that process is humbling, right? And
Yeah, I'll
you
say.
know when you when I work with them and talk with them, it's not ego based. It's they're trying to figure out what's the best way, and that process again, I think, grounds you. So,
Hmm.
um, but with collage again, watching the infant develop, the concepts and principles of the diaphragm kind of being the main instigator of the facilitation of both respiration and stabilization is what he recognized. So, and then what's that controlled by? That's controlled by the central nervous system. So with the videos that we went through, it just shows the animation of that respiratory pattern, that stabilizing pattern, and then the coordination of the two, um, that we're trying to assess, but then also treat and help our central nervous system still express, because we still have that in there. We just override it with compensatory high threshold patterns, which we can get away with until we can't, right? The high threshold compensatory pattern catches up with us, creates
What's an
overload.
example of that, Mike? For those of
Um,
us that aren't as familiar with DNS, what's a high threshold compensation?
so, if the coordination of the diaphragm and the reactive stability of that deep stabilizing group of musculature, pelvic floor, entire abdominal wall, intersegmental spinal musculature is thrown off, then instead of that synergy and this nice symphony of activity of all the musculature to create that dynamic stability throughout full range of motion, what we see is, for example, if we look at the lumbar spine, we'll see adaptive shortening, tightening, overactivity of the extensors, the paraspinal musculature. We'll see overactivity, adaptive shortening of, the hip flexor complex, sartorius, rectus femoris, lateral quad, TFL. You'll also see adaptive shortening and tightening of the deep external rotators. And that will create certain postural distortions. You'll tend to see obliquity of the pelvis. You'll see, a popular compensation pattern. Posturally, you'll see we call it a scissoring pattern, where you'll have anterior tendency for a more anterior pelvic tilt through the pelvis. You'll see an inspiratory. The thoracic cage will be elevated, and that will then that will increase loading. You'll see increased loading through the transitional areas throughout the spine. So lumbar sacral junction, TL junction, CT junction. Where do we see all the degenerative changes in disc pathology? Those
Yeah,
transitional areas throughout the spine.
right.
Then you take it, more into the kinematic chain. You got FAI, hip impingement, shoulder impingement. You go down to, uh, pitchers and
Yeah, the UCLs. Yeah,
UCLs. So it's uh, you know those symptoms and tendinoses, tendinitises, Achilles tendonitis, plantar fascia. You can recognize the pain generator. You can recognize that pathology, but then the question, okay, why? And for me, and for Prague School, assessing the efficiency of the deep stabilizing system will usually give you the why, unless it's like an acute traumatic type injury, right?
sure.
With the chronic injury, you're gonna recognize. You can literally see it. You can see the overloading. You can see the adaptive shortening, and you can feel it. With the
Yeah,
soft tissue, right? You feel the quality of the soft tissues.
yeah, big time.
So
And even in the traumatic ones, I find that they're usually set up. It's a big setup,
yeah, yeah,
and it took years to make that setup to have that one moment where things aren't reacting quite enough to be able to protect that joint physiologically, and something blows. But
right.
that's not every time, but that's most of the time in my
Yeah.
experience.
Yeah, and that I know definitely, unless you get hit by a car, so something
Yeah,
like that.
yeah, right, right.
But like the non-contact injury ACL, right? It's if that underlying synergy of stability, dynamic stability, which then allows for optimal position of joint structures throughout the chain of movement. If that's thrown off and they're reliant on that compensatory high threshold pattern, then they also become more susceptible to those acute injuries, ankle sprain, ACL, um, whatever, shoulder dislocation, or not dislocation, I should say. If you get slammed on the ground or something, you're going to
Yeah,
dislocate the shoulder. But then once you have those injuries, it just perpetuates the more of the
yeah,
compensatory pattern, because your brain's doing what it's designed to do, which is compensate to help you survive, to achieve the task that you're trying to achieve. Problem is, if that high threshold compensatory pattern becomes the go-to all the time, not just when you're maxing things out, but when you're picking up this cup to take a drink,
yeah.
and you're like this, then
Right,
that's
right.
going to factor into the chronicity of what you're dealing with.
Yeah, yeah, yeah,
So,
absolutely. I mean, that stuff sticks, man. Doesn't just
yeah,
go away. Just like when we're all sitting here, and what we're doing is firing the four horsemen up, right, of the lumbar spine, so that when we stand up, they're still fired up, right? So unless we're really on that, we know which ones to stretch out. We fall victim to the very same things that brought us into this business to begin with. So we have
right.
to practice what we preach. It's the only way for us to be genuine and authentic. And Mike, I've always found you to be super genuine and authentic. So I just wanted to let you know I really appreciate that, in our relationship over the last couple of decades at least. I've noticed those consistencies, and just appreciate all you bring to our profession and everybody's profession, and especially to all the athletes that you've worked with. I'm sure they feel the same way.
Yeah. Well, thanks right back to you, because you're a huge influence. You kind of set my early on, just my mindset and view of how to ideally approach what we do. So thank you
Oh,
right
thank you.
back. Yeah.
Yeah, thanks, man. Appreciate it.
Well, and to Tim's point, the athletes thank you, because one of the things that you both preach and focus on is an athlete centered approach where it's not about us, it's not about our egos. Everyone's on the same level. We're all learning from each other, with the athlete's benefit in mind. And I think that, to Tim's point earlier, that's kind of what we all would have wanted as younger athletes ourselves. It seems to be a common theme, going across all this. And I think that we'll get to some questions at the end regarding what we know now and what we wish we might have done, back then or had exposure to. But to kind of close the conversation around, just better understanding DNS, could you pull up your presentation real quick, share your screen, and maybe we go through a couple of the slides, especially the slide that shows the DNS based concept of the 3-month progression, all the way through to 18 months, to give everyone kind of a better understanding of how you go through, not only from assessment to, then somewhat of the assessment, becoming, really some of the exercises and movements that help to retrain those patterns.
Okay, so in this slide, this is illustrating there's 3 levels of motor control. One, when we're first born, the the spinal level and brainstem level are kind of dominant. They're helping keep us alive. This is the first 4 to 6 weeks of life. This area of the central nervous system dominates, and that means primitive reflexes dominate. And also at this time, we have no real postural function, no balance. We're asymmetric. We have undulating, writhing movements. And functionally, structurally, we're not mature. So our bony structure is not mature. Our central nervous system isn't mature. By 3 months period of time, we have the subcortical region of the central nervous system maturing and then starting to express itself. And the motor patterns that are expressed are the ones that create the synergy, coordination, and timing of that deep group of stabilizing musculature: diaphragm, pelvic floor, the entire abdominal wall, intersegmental spinal musculature throughout the spine. And from 3 months, 3 to 18 months, or, the first year of life and kind of beyond into 18 months, we have the subcortical region of the central nervous system maturing. And this is where we see that our postural foundations are established. If the central nervous system is healthy at this time, we have a healthy environment to explore this developing central nervous system, then we see, again, the synergy of agonist antagonist throughout the chain of movement. We see the ability of the diaphragm to initiate ideal respiration and stabilization. And as that region of the central nervous system is maturing, we have a dampening of the primitive reflexes. So we're overriding the primitive reflex prominence. And then from 2 to 6 years and beyond, that's where we have the higher levels of the cortical region of central nervous system maturation. And that's where we get motor learning, fine motor skills, agility, and all the things that we like to see with our patients and with our athletes. And this slide here, this is the representative of 3 months to 13 months. And the big thing that you're looking at here at 3 months, prone and supine, the infant has the ability to create the fixed point or sagittal stability through the trunk and the pelvis. So it can lift its head out of the base of support. It can start to explore its environment. And now there's more motivation to explore that environment, more drive to explore. In the supine position, it can lift its legs out of the base of support. It can bring its hands together and it's to its mouth. As that central nervous system keeps maturing, we get more and more efficiency of that deep stabilizing system, which then also means more and more efficiency of unloading, uprighting throughout the spine, which then means better, we call functional joint centration, with all the specific joints throughout the chain of movement. And as we progress, you see higher, more unstable positions. An infant can eventually turn over, come up to quadruped, hands and knees, crawl, kneel, squat, stand, and eventually walk. So as our central nervous system gets more and more efficient with that quality of deep stabilization, we attain higher, more unstable um, positions, eventually walking. Another key thing here, so you have the infant going through those specific developmental milestones at certain times, but we also see the adult, and the adult um, is representing, um, as an adult, we have different limb lengths, we have different shape of our thoracic cage, the proportion of our head size to our body is different. So we have different proportions, limb lengths, we have different mobility because now we have hard and bony structures, etc. Um, but the thing we have in common with the infant that went through these developmental milestones is we still have those inborn hardwired motor patterns. We have the ability to express them, to subconsciously express ideal respiratory postural function, the diaphragm, deep stabilization, optimal joint centration throughout dynamic range of motion, dynamic movement. Um, so it's not that, and most of that specific active exercises that we utilize are based off of those developmental positions. And we base them off of those positions, not just because the infant did it, but when the infant's developing, as the central nervous system is expressing itself, and as the infant doesn't wake up at 6 months and just achieve a position. There's this whole maturing process. It's like a 3 to 4 week process. And if you look at the developmental milestones, you see, 3 to 4 weeks between each developmental milestone. So during that time, as the central nervous system is expressing itself, the infant's are also exploring its environment, finding optimal points of support on specific, uh, you know, uh, structures, the hand, the foot, the medial condyle and elbow on the forearm, the medial condyle on the knee, lateral condyle on the knee. And these areas still have huge proprioceptive input where if you load them properly and ideally you fire up the central nervous system, like automatically these kind of pure ideal inboard hardwired motor patterns express themselves. And so we utilize that knowledge of developmental kinesiology, optimal joint centration, optimal loading to kind of fire up the central nervous system to then override the compensatory high threshold patterns that usually set in, due to, the nature of how we live. So this is a great slide illustrating that specific uh, concept and principle of DNS, which again is hugely based off of developmental kinesiology or postural ontogenesis.
That's wild. And I note nowadays, Michael, more than before, athletes are coming to me and they've had some experience with DNS and they're starting to capture some of the terminology you use, like high knee and whatnot, when they're describing positions that they're having troubles getting into or getting out of. And I think that's just fascinating and just speaks to how DNS is coming from Czechoslovakia and growing in the United States.
Yeah, definitely. Um, a nice, John, I don't know if you want me to go to another slide.
Yeah, and obviously the diaphragm is a big player in this process, and you kind of alluded earlier to the illustration and the video. I think it's a little ways back where it actually shows the process of the diaphragm actually working and the rib cage expanding and how that kind of plays into postural function and stabilization.
Yeah. So, here initially you see this nice corset, right? We have internal, external oblique, we have transverse abdominis, we have rectus abdominis, and it all attaches through the thoracic cage, through the pelvis, And here next, this is kind of stripping it down so you can see as the diaphragm descends, we see that nice expansion through the abdominal wall. We'd also see, motility of the viscera, expansion of the pelvic floor. So that the cylinder on my right is illustrating respiration right now. But then as we get to stabilizing function, here we see the stabilizing function. So diaphragm drops more, creates the stabilization, eccentric, isometric activity. But now we still need to breathe and move. So this is illustrating how the central nervous system is coordinating the activity of the diaphragm as well as the stabilizing function. So, for example, if I'm playing tennis, if I'm playing soccer, if I'm running a marathon, I need to stabilize here and I need to still breathe. And if I need, so the diaphragm is still being utilized for respiration. The abdominal wall is managing and maintaining the intra-abdominal pressure to create that stable fixed point through the trunk and the pelvis, where a lot of the transfer of force and load is going to be occurring. And the more capacity and that I have to maintain that coordination, then the more efficient my movement, the more durability and longevity I'm going to have within the the sport that I do or my just daily life. In this last view here, we see the abdominal wall wraps all the way around. So we have the abdominal wall, and then we have thoracolumbar fascia, quadratus lumborum, serratus posterior inferior. This is this nice, huge corset. And again, with the ideal synergy, the ideal symphony of activity being expressed by the central nervous system, provides optimal transfer of force and load and helps us maintain that efficient, ideal movement.
You also had a great slide that showed a number of different athletes, I think from Roger Federer to Kelly, to maybe Tom Brady as well. And, kind of pulling all of that together, if you could kind of elaborate on, how all of these athletes utilize, the benefits of DNS to not only improve performance, but from an injury prevention perspective.
So the javelin thrower is Jan Železný, 3-time Olympic gold medalist, 20-year career in javelin, which is huge as far as longevity.
Wow.
And he was kind of Collage's muse, or kind of like Pavel's ideas and concepts. He was able to work with Železný throughout his career and integrate the ideas of dynamic neuromuscular stabilization. And so, we have Jan Železný, you have Roger Federer, Nolan Ryan, Kelly Slater, Tom Brady. So these are athletes that have really nice postural foundations, but also amazing cortical function, right? Body awareness, being able to process their environment, then throw on top of that drive, motivation, mindset. So and what I like pointing out here is they all rose to the top of their professions, the top of their sports, and they all had durability and longevity, throughout their career. And they'd still get hurt, but they would recover quickly. And there's other athletes can still achieve these goals, but they may rely more on speed and strength to achieve that goal instead of the synergy of optimal postural foundations, optimal cortical function. And the the durability and longevity aspect of this type of athlete is exemplified with that combination of what I said with optimal postural foundations and cortical function, etc. And if you look at these guys, they're not necessarily the strongest, they're not necessarily the fastest. They just put it all together so efficiently. And if you watch them move, that efficiency makes it look effortless. They efficiently stabilize where they need to, they efficiently relax where they need to, and then they can move fluidly to achieve their goals. With Jan Železny, one of major training methods would be focusing on synergy and timing of the technique of the javelin. And there's stories of where he'd go to camps, and with practice he'd be working on timing and sequencing and the feel of the activity. And so his throws weren't that far, and then other guys practicing would just be bombing it way past him. So come competition time, those guys would think, oh, I'm going to just destroy this guy. But he would save it up for competition time and just put it all together. And then, so he wasn't overtraining. He wasn't burning himself out. He wasn't exposing himself to the overuse injuries.
Huh.
So, and the other thing, if you look at like Federer, he's got a good team of trainers and coaches around him that allowed him to maintain that optimal functional capacity, because having an ideal team around you can be the difference of that durability, longevity, or not optimal training or overtraining that then compromises the optimal expression of the central nervous system. And you see that in with all different athletes. This other slide here, what I like about this is these are all high-level professional Olympic athletes and professional athletes, and we have different genders, ethnicities, body types, and sports that are represented, and they all are expressing those same inborn hardwired motor patterns that we do within their body type and gender and ethnicity. And different body types can lend to success in different sports. And so if you have that body type as a basketball player versus a gymnast, right? Probably not going to see a basketball player on the balance beam, or maybe you will, I don't know. But gymnast is probably body type more suited for that, but there's still the same expression of synergy, coordination, timing that takes place to help them achieve the activities that they can achieve.
Yeah, I remember fighting over that slide for a few years when we were doing talks that were, in the same symposiums or whatever. And though our approach was different, I know that you talk about everybody shares a nervous system here, so everybody's the same,
Yeah,
and it's the same with me. Using the checks work and research, and specifically Yanda. Every one of these people have predictable imbalances that you go in with as well, and so it's really interesting how, again, we're taking different approaches to accomplish the same thing, but I just find these things just super compelling. So I'm glad you threw up that slide.
nice.
Yeah, and Mike, going back to your last slide, with all the athletes, Tim, you spent a lot of years working with Kelly. Do you maybe want to just kind of, share your experience of when you kind of first took him through an assessment, and, Mike talking about the ability to be able to call, on your body and have it move and stabilize and react and respond, as you need it to, once again, whether from an endurance standpoint or a performance standpoint, it's pretty unique the way that they have the ability to be able to react and respond.
Yeah, Kelly was already doing incredible things before I had anything to do with him. So, my job was just to, just help him out as much as you can and get the hell out of the way, because this guy's really something different. And the one thing in his first examination, I started working with him when he was about 17 years old, and just had a conversations with him today. So our relationship still rolls after all these years. And one of the first things I saw in Kelly was that not only his ability to be super present, but his body had he didn't know where all these things came from either, but I took him through them just for an example, a lumbar exam. So we take you through flexion, right? You're going to bend forward from the waist, and of course went down, put his palms on the floor, so that's nice range of motion, and a great place to start. Then I had him come up and put his hands on his hip and go into lumbar extension, so going backwards. And he said, "Well, how far do you want me to go?" And I said, "Well, how much you got?" And he just goes, "Well, I have this." And he started to go backwards. He goes, "More?" And I go, "Yeah, show me what you have." And he goes all the way down, does a back bend, puts his hand on the floor, touches his nose to the floor, and stands up. And I just went, what am I going to do for this guy? So I mean, from the jump, he was a phenom, but also has always been so curious. I mean, he spends so much time learning, that I would put him at the table with just about any intellects I've ever met in my life, and just would love to sit back and watch him go at it, because he's got great knowledge about a lot of different things. But
Nice.
besides that one thing, besides that incredible mobility, Mike, and I don't know if you've noticed this on super, super elite athletes, as tight as they may be, their body still yields when you touch them.
Yeah.
So normally when I'm tight, if you hit me in a tight spot, my body's going to tighten up. The guys, like the Kobe's and the Kellys and the Lance Armstrongs and those that have reached super high level of athleticism, I've noticed when touching them, this is the phenomena that they present with. And
Yeah.
I take it to the next level of saying, well, this is how they communicate so well with their body, from brain to action, from the body's ability to send afferent signals back to the brain so the body can adjust on a trigger's notice. So, that was, what I noticed with him, John, probably the most notable things, beyond just his relentless attitude to get better, and
Yeah.
the thing that he shared with Kobe about losing. I mean, you don't go out necessarily to win. We all do, but you don't have that in mind. What you do is you go out with the need to learn. This gives me a great chance to learn today, no matter what the circumstances are. So I think those were some phenomenal things about him, and I could still check off some stuff on different boxes, but that's probably what I'll leave you with. What do you
Yeah.
think, Mike?
Yeah. So the one example I have is, early on when I was on the PGA Tour, I had opportunity to work on Tiger Woods,
Yeah,
and he came in. Um, he just wanted to get kind of prepped and loosened up, and so I started doing some tissue work, and I noticed just had this suppleness, right?
yeah,
Uh,
that's
like, yeah,
great term.
normal people, you can feel the soft tissue restrictions, trigger points, etc. And I'm just going like, there's nothing here, right?
Yeah,
So there's just
yeah,
this suppleness, and then range of motion. I'm going to stretch them, and it just keeps going. And I was like, okay, now I get it.
wow,
This is why
yeah,
these
yeah, yeah,
guys. But on the, you know, to the other point with ideal training methods, uh, I also saw with him as he went into more of the high threshold training, hypertrophy and focusing on just the strength training, is that suppleness, that range of motion, the accumulation of injuries compromise that ideal expression of the central nervous system. That's where it comes into
yeah. Wow.
having that ideal team with the same uh, ideas of the ideal methods or things to address to help them maintain their natural
Mm,
ability is
mm.
huge, and it can make
It-
or break, right?
Wow, wow, Mike, you
Yeah.
saying this just makes me flash back on working with Kobe in the earlier years when he had, I don't know who's listening to this podcast, but when he had trainers around him that wouldn't let me do mobility work with him.
Right.
They just wanted him doing Olympic lifts, getting thick, and not worrying about flexibility and mobility. And I was just like, what planet are you on? And they were asking me for literature on why I think he needs to be mobile. And it's like, well, I can back up an 18 wheeler tonight to your house. There's so much literature on how important mobility and coordination and
Yeah.
stabilization is. So, back to your point, man, I was just
Yeah.
blown away. And when he did, because Kobe got thick for a while, man, and his injuries just went boom. Much
Yes.
harder to work on him.
Yeah. There's a story that Collage talks about with Jan Jelezny, the javelin thrower. One season he went with a different coach, and they're like, "Okay, we need to get you stronger, right?" And so yeah, he got stronger. He could jump further. He could lift more. But guess what happened to his throw distance, right?
Really, really.
Decreased.
Wow.
Because he
Yeah.
lost the connection. He lost
Yes.
the synergy and the timing that you really need to generate, the kinetic forces to, especially with throwers.
Yeah.
But in Tim, I don't, working, teaching to different teams. I've presented to hockey and baseball. There's always this kind of disconnect with the strength and conditioning staff and the rehab staff, because
Yeah.
the strength and conditioning staff is like, look at the numbers, they're
Yeah. Yeah.
strong,
Right.
our
Right.
job
Right.
is done.
All the
And then
linear numbers.
yeah, the rehab staff is like, yeah, but that's working against them, right? It's
Yeah.
feeding
Yeah.
them
Yeah.
compensation, and they're still getting injured. And then they talk to management, and the strength guys are like, "We're doing our job. It must be them," right? So
Yeah. Yeah. Yeah.
it's
Yeah.
always
Good.
this,
Great point. Great
and it's
point.
always
And you need them
surprised.
both, right? I mean,
Yeah,
they're
yeah,
they're wonderful people. They're super knowledgeable, and
yeah.
don't get me wrong. Strength training's huge, but there's a time and a place for it. And if you don't have a foundation to load, you're gonna break.
Yes. The trick, or the, I guess, the secret sauce is, how do we get allow those two groups to communicate in a way that's going to benefit the player. It's not just numbers, but it's, again, uh, for me, the DNS assessments and everything can give you the why, right?
Yeah,
The Okay, this is where the inefficiencies are. Yeah, you can get stronger, but guess what's going to get beat up, eventually. And that's with my own experience, just with my own body too.
makes perfect sense to me, Mike.
Well, and that's a
Yeah.
perfect segue as we kind of start to wrap up a little bit. Going back to, I keep referring to that slide. Whether it's Kelly or Jan or Rogers on that slide, and you were a tennis player. Knowing what you know now, experiencing what you've experienced, going through what you've gone through, seeing others with their challenges and their progressions and their regressions. Looking back at you as a high school tennis player, we've got a lot of younger athletes, and some even professional athletes who are still young in their career. What would you have done differently, personally, and especially, there's a lot of, we work with a lot of pitchers who have pars fractures, volleyball players,
Right.
overhead extension athletes. What would you personally have done differently? And then, what do you tell your younger athletes right now that's really critical and important for them to work on and address and be consistent with? Rehab isn't about you're hurt or something's bothering you or there's an issue and you just doing stuff until that goes off your radar and going away. I mean, it's really, the stuff that we probably should be doing on a daily basis for life if we want to stay active, well into our later years, whether it's, golf or whatever it is, surfing. What are a few of those things?
So, I mean, yeah, looking back, and I look at videos of myself and pictures, and I can see textbook, inefficient patterns. And, you could take a highlighter and just fast forward to me at, 18, 19, 20, and where I'd fall apart. So, one, I wish I had that knowledge, or at least I wish I had trainers and coaches that had that knowledge to recognize inefficiencies. Because, back when I'm 12 or 13, going through puberty or just before puberty, where you can really recognize the dysfunction. Um, uh, I wish that they had that knowledge, and then they could have done things to address it, because then that would have helped me reach my potential as an athlete and not have to go through the whole repetitive injury cycle, which just suck the joy, out of
Yeah.
the competing. So, um, the tough part there, and again, working with especially youth athletes, more and more they're coming in younger and younger with overuse injuries. That's usually going to drive them to me. And if we can intervene quick enough, and I can educate them on what's going on, the underlying issue to why the injury occurred in the first place, and then take them through specific, what we call active exercises, helping them feel the ideal facilitation, and then develop a specific targeted movement preparation for them, for their sport, to help enhance the expression of this ideal synergy, coordination, timing of the central nervous system. Then one, they stay injury free. Two, they perform better, and again, they enjoy their sport. So
They're also creating engrams, right? They're creating movement
yeah,
engrams in the brain.
yeah,
And so those things, the deeper those grooves get, the longer you maintain that. So, and
yeah,
that's, I mean, when we have an injury, right, we break that down and we lose that connection.
right.
So the deeper those grooves are, the more the body can remember it sooner after your injury.
And it works. Yeah, it works both ways, right?
Yeah.
It can
Yeah,
work
it does.
positive, or it can work the ingranation, if that's a word.
I like
So
it.
It is now.
is now works the other way. So what I try to do, if I can, the earlier I can catch an athlete, the better. And the earlier, the quicker they respond. I can give them a few things. The problem with the younger athlete is they, once the pain goes away, they're like, oh, okay, whatever, right?
Yeah.
So
Yeah,
it's
it's our society.
trying to educate them for the long term benefit. The highly motivated professional athlete, Olympic athletes that I've had opportunities to work with is one, soft tissue mobilization, recognizing the inefficiencies or the compensatory patterns, educating them on that, uh, utilizing specific developmental milestone positions to help them facilitate more efficient patterns. And then again, giving them not just like the static positions, but showing them the transitions from one position to the other, where they're maintaining optimal joint centration, maintaining optimal activity of deep stabilization. That's where you get the full integration or expression subcortically. And that's where you get to the point to where they don't have to be thinking about it, which is,
Mm.
that's where they need to be. It's
Yeah,
just
that's huge. That's ultimate, right?
yeah, it's like learning, you learn golf, for example. What do you do at first? You're flailing, right? You're all over the place. A
Yeah.
lot of times when you start addressing the inefficiencies, same thing. They're all over the place. They're like, what the heck's going on? Why can't I do this? And you have to educate them. This is a process. Just like there was a process during development, just like there's a process learning a specific sport, technique, etc. It's a process of getting that back. And so
Yeah.
that's a
And
big
isn't it true that it's much easier when they're young, right? They're very plastic. And
yeah,
instead of taking 10,000 reps, it might take them hundreds of reps.
yeah.
And then to relearn it as we get older, that's where we have to toughen them up and let them know they're in for a big battle here, because the body's it's already locked into a pattern. It thinks that you wanted that pattern and
And
now
not
you're
only,
going to change it, right?
yeah,
That's a tough battle.
it's tough, and what's also tough is there's usually wear and tear, right? We have
Yeah,
degenerative
right.
changes.
Yeah,
thoracic
very good.
cage is like a block of concrete, right? So there's a little more work involved, a little bit longer process, and maybe you're not going to get all the way there, but you can make huge improvements,
Huge.
and create an environment around the structural issues or the restrictions, to help them, improve as much as they possibly can to then,
Yeah,
you know, one, get out of pain, two, increase performance, again, whatever their goal is.
right on.
And if you'd like to see Mike live and in action, doing DNS demos, and also Tim demonstrating SPRT therapy, soft tissue, and some of the functional sensory motor taping, make sure you come to the SPRT Therapy Sports Movement Symposium in June. You can go to sprttherapy.com to register. Also, Mike will be presenting as well, hopefully, at the Surf Movement Masterclass in August around the US Open. Or Claire Frank will be there as well, demonstrating DNS. If Mike, you're traveling, maybe you're going to Japan, I think, during that time.
August, July, I'm going to Japan. What are the dates in August?
Yeah, that's right around the U.S. Open of surfing. So I think it's August
First
1st
and
and
second.
2nd, right?
Yeah.
So
I
we'll
should,
clear that up. We're going to get you there either way. If we got to send the jet to bring you back, but I guess my
be around, yeah.
Yeah, my point is that, you can see live and in person Mike, taking athletes through an assessment and then giving them, exercise modifications to address these. But maybe, to give a practical application, and I don't know if you can do this, but, going back to the beginning of this conversation around your personal imbalances, can you just explain what, when you look back and you see, what specifically are you seeing? Are you seeing valgus? Are you seeing rib flare? Like, what are some of the things that you saw personally that, would have been the first couple things that you would have corrected or started to work on?
Um, for me personally, respiratory pattern. I was, uh, you know, premature, so my development probably wasn't the most ideal. Premature baby, and had a lot of allergies as a kid. So my breathing pattern was mouth breathing, and with that, you're going to see that tendency to utilize more of the, because I was always congested and stuffed up, and um, so my strategy was more of that high threshold pattern, the utilizing accessory breathing muscles when I'm just sitting here, doing certain things, and that not only is not as efficient as utilizing the diaphragm, but um, early on, those inefficiencies can affect the formation of your thoracic cage and bony structures. If we have synergy, coordination, timing of an agonist antagonist throughout chains of movement, then um, that affects the formation of bony structures. So I have a pretty good kyphosis, and it's fixed to some point. So early on, if I could have addressed that, my quality of respiratory function, I think that would have been huge. The other things that I've seen and recognized is just, again, those high threshold compensatory patterns that I just relied on, because my strategy was, okay, if I work harder than this person, then I'm going to achieve more. But I just ended up just beating myself up and not able to reach that potential. So, more optimal training strategies, addressing my respiratory function and deep stabilizing function. But unfortunately, you know, that knowledge or that help for me was not accessible. So, um, those are probably the major things. And if I could have addressed that the earlier on, the better. Where I really started to notice, and where I can see in pictures is, 12, 13 years old is just like, yeah.
Yeah, the respiratory stuff, and then you're in school every day in the shit
Yeah.
posture, and that just fed the dragon.
Yeah, yeah.
Well,
And
we had,
the
go ahead.
I was just gonna say, and I mean, you guys know with respiration, right? If you're constantly going to accessory breathing muscles, what's happening to the autonomic nervous system? You're
Fight
in
or flight, baby.
fight and flight, yeah. And then you put on top of that stress and all this other stuff that's going on, and it's just that's another huge influence that can affect that quality of synergy, coordination, timing. So, you know, there's lots lots of things on all levels that would have been great to address back then. Now having that knowledge, when I do see patients, I take all that into account and then try to educate them on that and their parents and et cetera. So yeah.
That's really great and really helpful. And we had Dr. Skip George on the other night, and he mentioned Professor Collage's quote where he says that the most common movement imbalance is breathing um, in general. And so, um,
Powerful.
yeah. So, before we go any further and get into any questions, if someone wanted to come see you speak, can you just kind of share your information as far as your website is Rintala Movement Designs. They can find you at Rintala Movement Flow on IG. You teach a lot of courses. You're traveling around the world. Can you just kind of let everyone know where they can find you and how they can find you and maybe something about what you have coming up?
Yeah, yeah. I mean, yeah, social media, Rintala Movement Flow, Instagram, Michael Rintala DC on Facebook. Rintala Cairo is one of the websites that has all the listings of the upcoming coursework. And then Rintala Movement Designs also has that, but then there's also, you can get access to different videos and tutorials and other opportunities to learn DNS. As far as upcoming coursework, um, as far as introductory coursework, um, in I think I got to remember this. There's September 6th and 7th, there'll be a DNS exercise sport one, which is a great introduction to the concepts and principles of DNS. You get assessments, active exercises, and it's open to both trainers and clinicians. There's something for everybody in that one. Um, in July, there's another one up at, I think it's Oregon State University. We're doing an introductory course to DNS concepts and principles, focus on sport and the active exercises. And there's probably many others that I'm just going blank. But if you check the website, you'll see it. And then if you go to Prague School of Rehabilitation, you'll see all the courses worldwide as far as upcoming coursework.
That's great. Well, for a more in-depth presentation on Dr. Mike Rintala's educational module, please go to webexercisesacademy.com. That's webexercisesacademy.com. And once again, you can get CEs for watching that more in-depth discussion around what we were chatting about tonight. Once again, to see Mike live and in person, you can check out the SPRT Therapy Sports Movement Symposium. And before we go, Mike, anything else that you'd like to
add? No, just thank you again. Love working with you guys. And again, you've been a huge influence on my approach and my career. So thank you again.
Yeah, the street goes both ways, brother. I appreciate you. Appreciate Mags and your family for putting up with all my antics over the years. And it's been great to have your support. Certainly adds legitimacy to the stuff I do, my man. So really appreciate you and look forward to the future where we can continue to blend this stuff and bring the young ones up the ladder and save them some years that we took to kind of get this stuff so that they can further advance the next group coming up.
Excellent.
Right on, brother.
Well, for Dr. Michael Rintala, Dr. Tim Brown, thanks again so much for joining us. Have a great day, and TV.
Stand tall.
Bam.
Bye, guys.
Thanks again for joining us for today's SPRT Therapy Podcast. Stay tuned for new episodes in coming weeks. And please check us out on Instagram and online at sprttherapy.com for upcoming events and discounts on live educational courses. Until next time, have a great day and stand tall.
I sway and not in the breeze as I lay on the beach, watch the sunset undress as I wind down.